Hello, this is case discussion trying to find the best solution. I'm moderator Dr. Kim Se-jin. Today, to solve your issues, we have invited clinical masters Dr. Kim Kyoung-won, Dr. Kim Yeong-taek, and Dr. Park Jong Hyun. Thank you for joining us. Thank you. Then let's see the case of today. 2014, I met this patient for the first time. The maxillar, both side posterior, periodontal, there were problems. 2015, at another clinic on the upper right part had implant and came back to me in 2017, and 2021 had on the left upper side implant restoration. It looks both side on the sinus mucosa detachment. It could have been maybe better. So these are my questions. First, on the right side, it's been 6 years, but ossification is not well done. So if there was a shorter implant, maybe there would have been more bone formed on the apex side. Secondly, even left side, which I did, there's a bit of detachment that's falling short, but thanks to shorter implant after time, maybe there's more probability of bones formation on the apex side. Thirdly, if the only apex had elevation after time, would there be more bone formation? Fourth question, with the crestal approach, if sinus lifting is done, then sometimes wall detachment is not done very well, and sometimes only apex is elevated. With crestal approach, would it be better to use shorter implant? Fifth and last question, with the 4 mm residual bone, with the lateral approach, if you place a 10 mm implant, then is it better for a patient than placing 6 mm implant on a crestal approach? That was very detailed questions, and we have invited the dentist who actually posed those questions here. So it's Dr. Park Jong Hyun who asked the questions. Actually, I tried also solve my challenges while talking about other cases, but today I have my own case. So two doctors. So what did you think? I think Dr. Park, in terms of sinus bone grafting, he has maybe thought more than I did, because for me, I don't really think much because I thought it was a bit routine. But with the Dr. Park posing these questions, it has also given me opportunity to think about a lot. Actually, these were also issues I was also thinking. So I was creating my own reference for this, but I've never really thought thoroughly. But with this case, I actually thought, yes, I should make my own more detailed references. So I did so. So I think it's going to be a very good discussion. So viewers, if you're joining us, think about what would you do. And if you have any good comment, please post them on the chatting box. So first, Dr. Park, what were your challenges here? Could you share with us? Yes, there's no thing I want to insist with here, but I just want to learn from you all. Now, 6 years ago, the CT was taken at another clinic, and I do not believe ossification was done very well. So when thinking the reason for that, first, I think it's because the bone growth factor coming I think maybe not such details. So you see there is another palatal, not much of detachment, and if you use material that's not very resorbable, even after time, histologically you see bones, but with autogenous bones mixing with the graft material, I think that's the situation. So this is my case. So in the past, I used synthetic bone with a lot of A. So if you look at cases, then even after time, bone formation is very slow. And with the time, of course, you see a lot of ossifications and autogenous bone being formed. But if it's not resorbed very well, because there is a lot of volume of HA, bone formation is usually very delayed, and bone quality on the X-ray was also not very good. Here, now HA share, do you know how much it was? Now, I use Osstem product, and for Q-Oss, HA was 75%, beta TCP was 25%. So it's a very high HA ratio, yes. So if you use this type of product, bone formation is further slow. And if you further analyze the case, this is what I detected. Sinus cavity, if it's large, then it's not so favorable for bone formation. That's what literature said. Of course, if you have a lot of time and if you have a favorable condition, it might be not so. But anyway, if you put shorter implant and sinus cavity only up to narrow, try to form bone there, then up to apex, bone quality wise could have been better. That's what I started to think. Now, this is my case. And again, here also, it was not really well done because on the wall side, detachment was not very well done up to the palatal side. So maybe because shorter implant was used, so bone formation is actually being prepared on the apex side. If I had to do this case again, maybe in 6mm implant I would have used. So long implant, whether to use it or not is my kind of issue today. Because what I found is up to broad cavity, bone to be formed well up there, then with the crystal approach, it's not easy. So like the professor here, if through the lateral approach, if I could create good environment for ossification, then long implant, like 10mm, putting there is okay. But with the crystal approach, then narrow sinus cavity only within that range, even if the bone volume is low, bone quality, I believe recently could be better. That's what I started to believe. So with this case, after time, short implants, when I use them, then bone ossification up to apex was quite well done. So my opinion is that for the sinus lift, the maxilla side, if you do it very well, it'll be good. But if you opt for crystal approach, then even if it's short, ossification that is can be done well up to apex is something you should consider. So this is another clinic. It was done, so it was impressive. So I took CT. It was really happy result. There's no tear, and I think there was no bone graft. But with this long implant, still bone is formed so well. But you don't really see this type of cases always. So another case from a literature. So if you have covered of the with the mucosa, I think it's okay. But for this long implant for functioning without ossification, what would happen? Of course, sinusitis probability is low, but in functioning, this long implant, what does it serve? Is a question that I always have. So this is animal study, but like this, if you have perforation and place implant rather than soft tissue, you first have germs, being attached. Then without removing implant, there's a lot of chance this developing into sinusitis. So this is another case. Now using guide, placed implant, and for 1 year, HA volume was high was the material that I used, and on the palatal side, the part that could have more bone growth factor became low, and because HA volume is high, bonification was rather slow. Of course, with time there will be formed, but if I had used here 8.5, but if I had no bone grafting with 7mm implant, maybe in terms of bone quality it would have been better. If 8.5 rather than 7mm, placing it here, has it really been helpful, is what I want to ask of your opinion. If I had used here 7mm implant and did no bone grafting, is it 8.5? Then 8.5 or 7, I think it will be similar result. With 7mm, you don't have to do sinus elevation. Yes, just very small. I think up to 8, there will be more ossification, because bone here, their functions, I don't think is very helpful. I think it's actually helpful, because maybe we should talk about the graft material first. In the sinus, any material is okay. HA volume being high and that remaining there for a long time could be an issue, is what you say. But the synthetic bone is not very good for bone formation, or bone is retained very well, but xenograft, bone formation is done well. But I think in my experience in looking at various references within sinus, it's really favorable for bone formation, because the bone can really come up from the bottom part. And I didn't bring that literature today, but Schneiderian membrane, they say, osteogenic, they say has a potential. And that was from Yonsei University paper. And Schneider membrane bone is formed. Of course, not all parts, but the bone can come from all sides. And so autogenic bone, if not that is used, if the volume can be made, anything can kind of goes. And here it's really good. Well made. So with 7mm, without bone grafting, then you cannot have bone on the apical side. And if you anchor in the bipodical side, I think that even itself is good result. In sinus being elevated by 1 to 2mm, as you have shown, it can be covered everything. So I think the sinus being elevated, it doesn't create a problems. So aesthetically, and also the various considering force that being on the implant, covering apex about that bone grafting with 8.5, I think that was the best option available. I think it's really well done a case. It's something you can be proud of. Maybe that's what I think. So with 7mm going short, inevitably, if in the sinus side, there is no consistency, then it's really hard for elevation. But in the extraction socket, the healing is not complete. Then in a challenge situation, 7mm could be an alternative, but basically 8.5 is something that you should go with. That's my opinion. So you did really well. So I do agree with Dr. Kim. Still, in the past, if you look at my implant cases, on the upper posterior, I even did 13mm. Of course, I don't do that. Nowadays, I usually go for 10mm. Of course, sometimes I go, if there's a reasons, 8.5. But not really up to 7 unless there is a specific reason. And you said that the bone formations is delayed because the HA volume is high. That's a characteristics of that material. So with that photo, I do believe it's kind of good result and well done. And personally, synthetic bone in late 80s, there's been, for me, bad memories about HA. So I don't really go for aesthetic bone still. But with those photos, I don't think there is a lot of issues. Well, thank you. So one of my problem has now been solved. So my opinion is this. Now, this sinus lift done well and wall side is okay, then long implant is okay. But if you do hydraulic lifting and crystal approach, sometimes it doesn't go well as you intended. Then with shorter implant, even if there's a perforation on the apex side, there's a soft tissue, and there is less chance of this creating problems. And if you look at cases like this, with the osteotome and then with the apex only type was used, and always for this approach, new radio-opaque line is created and the cortical line is absorbed and disappears. That's what is shown. So if the sinus floor covered in this fixture, then with the osteotome, you only do sinus lift with that, then I think it's most cases they had used short implant. Of course, this is my very personal opinion. Anyway, after 45 months, prosthesis is maintained very well. And if you look at this root X-ray, the existing cortical line has disappeared and new radio-opaque line has been formed. And to me, I see that a lot with the short implant. What do you think? This is 7 millimeters? Yes. Actually, if you're going to use osteotome, then 8.5 would have been okay. I mean, 10 would be too much. I think that would not be a good option. But 7 to 8.5, it's all okay. And you said there's a line on the apex side. Then actually bone about 0.25 grams filled in terms of forming good lines later on would been good. Also, of course, on short term, this or that would have good same result, but HA being there for a long time could be an issue. But if you're on a long-term basis, like 45 months, then on the sinus, that bone graft material being there, maintaining volume, and creating good bone forms and distributing the force, I think would have been okay. So this type of results, I think is okay. Actually, for me, I don't really use short implant because, yes, it's very easy for surgery, but I'm afraid of being criticized by prosthodontists because I don't do prosthodontic treatment. So still using short implant, of course, I'm going to talk about literature a bit later on, but on the lower posterior side, short implant, the bone housing is different, so still they say it's okay. But on the upper side, a short implant, there is a chance, and even literature says there could be prosthodontic complications. So honestly, one of the reasons I don't go with the short implant is because I feel sorry for prosthodontists. So like Dr. Kim said, if I'm going to go with it anyways, and Dr. Park, crystal approach, it's a blind area. So we don't really know during surgery what would happen. So being too negative and trying to be too cautious might not be the way. If you do pumping incisions well, then I think its elevation can be done quite well. So it's a bit different with the osteotome we had used in the past. Actually, when you place 10 millimeters, to do prosthesis, it's the same. So prosthodontists, they say 10 millimeter, they might welcome it, but 10 millimeter, advantage, it's about 1 to 2, it might be 1.8 to 2. It becomes longer, it's more favorable, because the ratio is better. So that's that advantage. But here, what is more important is not implant to crown ratio, but crown height space. The crown house space being an issue if it's more than a few millimeters. I don't remember numbers, but there's a literature. So it is something you can recover with. So I think short implant is therefore allowed. And actually, single might be a problem, but you had a splinted implant, then you have 2 or more times of advantage structurally. So in that regard, it could be better. So I feel like I should think new about this. So like A, you have a lot of what becomes bone, it's not material, but where the bone growth factors can come needs to be secured so that blood comes and bone is formed. So like B, if there's less detachment and trying to put a long implant, then on the apex side, if HA volume is high in your material, then ossification is not really done well. But like C, if you place like the short implant sufficiently deep and then use material that is very well resorbed, then always you have acceptable results. And that's why I lean more toward C. So now looking back, I feel now this was QoS plus was used. So beta TCP volume is high here, so it's a bit more resorbable. So I secured a lot of space, and still, bone has been formed very well. This is because the resorbable material was used, and the wall formation was done also good. But if you look at number 16, the arrowed area, look at there, apex side, maybe compared to using short implant, what is advantage is something I try to ask. So if I do it again, I would have used 7 millimeters. Then on the X-ray, my opinion, it looks more comfortable. It looks bone formation done up to the apex very well. So what I'm still struggling with is there's not good ossification. Rather than them, short implant that gets good ossification up to apex would be better. That was my starting point. Why I use short implant more, it is simple reason, because I'm not very good with the retro approach. So I want to do crestal approach, and that's why I opt for more short implant. So why I have to use long implant? What is the base for long implants usage? I'm curious. So if you could give me feedback on that, it would be really good. So this is done in other clinic, and there was screw loosening, and I thought this was interesting. So if you see it, the materials was filled in unnecessary part, and with time, would it really be helpful? And something I thought about. And another thing I always think about is because I favor crestal approach, then if you have convex area, then there's actually more bones. I want to go there, but that is more challenging. So if you want to do lifting there, there's a lot of tension, and you end up having more perforation. So in this case also, there is always convex area I want to place implant, but if you do crestal approach there, maybe something different might be better. Meaning the convex is more bone, but there is more tension. So after 5 years, if you see the bone has been formed, yes, there. So another thing, perforation is issue. Long implant doing crestal approach, you probability-wise, there's more probability for rupture because you want to, do elevation more. So another case, looking at it, you see there's a loosening, so there's a perforation. So you detect there's a perforation. And, your gut tells you perforation, so I finish with short implant. So after placing short implant, even there's a perforation, soft tissue covers and, bone formation, I do believe becomes more likely. Wait, then here, perforation was checked with X-ray and you switched to a short implant? Even without perforation, I would have still gone with the short implant. But April and August, Of course, maybe enlargement size different, but compared to what was there in April, it seems you went in August with shorter one. Well, I don't remember. Maybe I saw the perforation and maybe switched to short one because the buccal bone, so there's more diameter and short in terms of length. Well, just leaving it there, although you switched to short one, but if you just left it there, then the perforated part physiologically within sinus, it would have naturally cleared. Rather than bone material, melts, absorbed, it would have been drained from there. So that's how you get to the apex. Then the lengthwise, it would have been more favorable. Actually, I'm still scared when it comes to sinus part. Well, this might be a good approach. As you said, for me, I would have just leave it be when there was perforation. But maybe I tried to give medication to prevent inflammation. That would have been what I've done. But switch to shorter implant, reducing the load, then that is more alignment to the goal of using 7 millimeters, because short implant was created to solve long implant problems. So using 7 millimeter as a rescue of 8.5 was also a good approach. I think you switched implant. I don't really remember. Let me know later on. So final prosthesis was delivered, and looking at these cases, I tried to solve with socket lift. So within narrow cavity, I tried to solve it. So I didn't go with the 7 millimeter because bone quality was really bad. So even if within sinus cavity, up to 12 millimeters, I try to lift if there's no specific reason to do bone grafting. So the radial opaque line has moved more toward upper part, and within narrow cavity, ossification becomes quicker. So other question has already been answered. So sinus lift with the Crestor approach, then it's really hard to be always consistent. So 6 to 7 millimeter implant is what I prefer. So on that part, maybe I would like to get your response. Dr. Kim Kyoung-won? As for me, actually, I use long ones, and because I'm teaching, the problem cases is what I mostly deal with. So I actually brought a fractured case. This is a first patient came in 2012. Tooth was extracted, and 2018 implant was placed. And my search shows, I think it was beginning of AO. So casket was used with the Crestor approach, and the SS2 5.11 by 11.5 was placed, which is one I don't use much anymore. And after about almost 5 years later, implant fractured. Actually, it's a male patient with a strong bite force. So it broke after 5 years, and because SS type bottom part fracture, so I could not use ERP kit. So using trap-in burr, I took it out, and as you can see in the last X-ray, after removing the implant on the top part, the AOS bone that I grafted with kit is maintained. So after removing implant with the trap-in burr, if it's now allergen or other bone grafting was done, but this was a local area, and due to cost issues, the patient did not want bone grafting. So after removing it, about 3 months later, this is when I replaced it. So I didn't do bone grafting, but there was not much of an issue. So after 4 years, 10 months, broken implant was removed, and then implant 5.0 by 10 millimeters was delivered, but bone graft had been done already. So without any bone grafting, implant was placed, and after about 3 years, it's maintained. So the initial using caskets with the Crestal approach, that been about 8 years ago, but the bone materials graft material is still functioning, and for me, in ossification, there was not much of a problem. So for me, I prefer long implants, as I said. So I think it's a similar case to Dr. Park. So I brought this. So this patient, it was done in clinic, not by me, but 27 was missing. So on the CT, residual bone height is about 4 millimeters. And the clinic doctor, through Crestal approach, placed SS type 10 millimeter implant and had used Osstem. And because of that, as you can see in the post-op CT, as Dr. Park says, sinus membrane has not been elevated. So here it's leaning more palatal side, so it was okay. But on the buccal side, the membrane has not been elevated, and graft material is just sitting on top of apex. So with the follow-ups, as you can see now, about 2 years, 6 months later, number 8 was extracted, and number 27 implant became loose, so that was also removed. And after removal and after implant failure, with me, we took CT, but nothing of the graft remained, and the bone quality was also not so good. So again, came to me for surgery. So for me, like this, for single on the upper part, I don't prefer doing Crestal approach. So in number 27, I had to place implant, and there is a host bone that's sufficient, no problem. But I have to do grafting. I think lateral approach would be better. So for number 27, depending on the patient, because it's on the inside, so approach might be tricky. So I did bone grafting, and with the fibrin blue, I did repair because there was a tear, and through sinus graft, bone graft thing was done, and 10 millimeter implant was placed, and about 6 years later, that's the last photo, grafted bone is maintained, and actually there is no problem, everything is functioning very well. So as for me, now as a surgeon, if I to open it, then doing for sure bone grafting is better to respond if there's any complication later on. Some dentists say you can do within sinus without bone grafting. So of course it's case by case, and if there is no distal freehand, there are teeth around it, that it's okay. But if you are doing approach, then I always go with the bone grafting. So that was the case. And for this case, actually in the past, with allogenic bone, I did the Crestal approach. So in 2011, with the casket, implant was placed, and about 6-7 years later on, this is what happened. Sinus floor from its initial position, as you can see, the bone material was put in there sufficiently, but with time, implant came down to the apex side. Because allergen was used, there was more resorption, but the implant top area, in the apex area, especially for allergen bone graft, then implant comes to the apex side at least. So especially with the Crestal approach, then, as Dr. Park has said, new cortical bone will be formed. But here it's a heterogenic or xenograft was done, and 26 and 27 was missing, and there with the casket, 3 implants were delivered with a Crestal approach. I think it was 10 millimeter implants. So we did bone grafting, and here, as I said before, I use bovine bone, and about 4 years later or so, bovine bone was used, but still now on the top part, bovine bone has disappeared and has come down to the apex side. So for me, crestal approach, then compared to lateral approach, with the lateral approach, if you create dome shape, it's retained. But with the crestal approach, you fill in from the bottom, so you cannot stack up. Hence, for most implants up to apex side, the bone comes down. Therefore, a bit, top part than apex. And using longer implant in terms of bone formation, it's more favorable. Basically, that's my opinion. So I looked up, and Dr. Park talked about short implants, so I looked up, and so Wang did 2019 this literature, and it's a systemic review. Looked at 18 studies and looked at about 1,600 implants, and looked at 793 extra short, less than 6 millimeters, and 820 long implant, and survival rate for 1 to 3 years. There was no statistical significant difference, so both were okay. And when it comes to extra short implant, marginal bone loss was less, and biological complication was less, and in terms of surgical time and treatment cost-wise also was less. However, prosthetic complications, when it comes to that, the long implants reported less, significantly less, and it was the report, and the conclusion was, as for 6 millimeter or less extra short implants, for 3-year follow-up on the athropic posterior side, it could be an option, but for long-term effectiveness of extra short dental implant, that requires further study. That's the conclusion. So I find that maybe short implants would not be, good with the prosthodontic treatment. And there's another systemic review literature. So it started with 1954 references, and a lot of were filtered out in between. But for short implants, less than 6 millimeters, survival rate-wise, compared to longer implants, there's no problem in the short term, but in terms of long-term follow-up, actually it was done in China, so there was no clear definition for long-term follow-up in this literature. But compared to short implant, survival rate is poor. Of course, this is a systematic review, but in terms of marginal bone loss, short implant or long implant, there was not much of a difference. And the conclusion of this paper is that short implant itself, as Dr. Kim has said, clown to implant ratio, in terms of CI ratio, it's higher. Hence, in terms of marginal bone loss, there could be issue, but the reality is there's no effect coming from there. But when it comes to short implant compared to long implant, on a long term, the survival rate is short. So if it's a single implant especially, then on the posterior area, there could be more problems. But of course, long-term follow-up is needed again. So as a surgeon, looking at those systemic review, me first opting for a short implant, I become hesitant. Thank you for that. Now, lastly, Dr. Kim, Yeong-taek. Well, before that, to Dr. Kim, I have a question. Then recently, what kind of surgery do you surgical procedure do you do? For me, it depends on cases, but crestal approach for distal freehand, if patient's young, young is ambiguous term now, but early 60s could be considered nowadays young. So if it's distal freehand, so there's no teeth at the back and it is 4 millimeter remaining, then I opt for lateral approach, do bone grafting and place implant. Then even if later on there's a complication, it's easier for repair, like delivering implant again. And if it's crestal approach and 4 millimeters, then number 5, number 6, if there is teeth at the back, then as Dr. Park has said, more narrow. Sinus within in the sinus cavity, if there's a teeth front and back, crestal approach would also be okay. Then again, I also have a question. Now, implant failed or became loose on the maxillary side. Then do you remove all the bone graft materials? I don't remove them. Of course, if it's an early failure, then implant had inflammation and bone materials was also there's inflammation and there was a failure. Then I remove all the materials, but implant that was being used and there was a loading. Then I just don't remove the materials. I think you have to look at the cause. If the osseointegration failed, resulting in implant failure, then if you look at the implant itself, osseointegration in the implant happens on few parts, not all. And there will be areas that attach the sinus or not, and that sometimes results into failure. So if you remove the failure inside, it's not because of the inflammation, but because of low osseointegration. It cannot withstand the occlusal force. So the bone to implant contact, so contact itself cannot withstand the load. So if you remove it and look inside, then the grafted bone sometimes is very hard. So if there's a fibers, then you remove them and you just wait a bit and then place the implant. Then it's like placing where there is bone. So no issues if there's a failure. Of course, if the inflammation you have to remove, but in other cases I don't remove. Then when it comes to crestal approach and lateral approach, I actually also thought about it, which is better, is what I thought. So I started with the lateral approach first. So I'm so familiar with the lateral approach. If you open with the lateral approach, then Schneider membrane, removing that, and putting bone graft material in there is more convenient. But when it comes to crestal approach, I use Osstem, so I don't use the cascade or hydraulic elevation. But it's really challenging. Crestal takes less time, but I have to really focus because you should not have a tear. And also in drilling, even if I know there will be tear, I try to stay within the line. And when you put the bone with the Osstem, I really careful, but with the lateral, you can just open. So I do under surgeons preferring lateral approach, but complication-wise, crestal is much better. They give more advantage, patient mobility. Crestal approach has, very low side effects. If crestal approach is done very well, they say it's very comfortable, and lateral approach, they find it really stressful. So, but not always. Patients don't complain like that, but maybe my patients. Anyways, so going with the crestal in the future, I think it's going to be the trend. But those that are doing lateral approach well, crestal approach, you have to be cautious. But there are also advantage. You can just open it. So I always tell students, do lateral approach well, and then familiar yourself with the crestal approach. If you're good with the crestal approach, it becomes easier. And with the perforation, if there's issues, then there are other options you can solve easily, like with lateral other things. So I think that is the best approach. So you practice lateral approach and be familiar with that too. So I actually have one more question. Then lateral approach to elevate membrane, it's better, but the bone growth factor, you lose one wall for that factor. So ossification, of course, with the CT, you have to make a judgment. But if you look at the CT, if you look at the quality, then I believe crystal approach is favorable in terms of ossification. It might look that way. Maybe yes, because I go with the short implant. But if you open with the lateral approach, if I may answer that question, if you open with the lateral, then you put in hole. In the past, you really created a window, really big window like cardboard. But nowadays, with the trefin, it's less than one in terms of diameter. So you open window, put the bone, and close the window, and use the tip, or you cover it with the membrane. So probably the problem was also something past doctors struggled with. So covering with soft tissue after bone grafting or adding membrane in there, success rate becomes different. This is because where you get the bone potential, whether you can get it from the wall or not, that it showed as a result in various literature. So if you have done lateral, if you don't open it too much and also add membrane there, ossification can be done. So Dr. Tana also talked about that too. But recently, I think lateral approach, and then I don't really cover it membrane anymore, because without membrane, of course, there could be some sacrifice in terms of bone, but in terms of implant or survival rate, in terms of all bone, there could be slight difference. But clinically, I do not believe it's a much of a difference. So for me, actually forming that, because of the lateral window formation, bone suffering, I don't think so. And on the lateral side, from palatal side, there's another side, there's a lot of blood supply. So I don't think you have to be too concerned. Personally, 2 or 3 implants need to be placed, or then from the classical cascade, using hydraulic elevation, that takes a lot of time, and sometimes it's a blind spot area, so I'm not really sure. I don't have visibility in surgery, but on the lateral approach, there is a visibility. So that's better. So I do agree with Dr. Kim. If those that can do lateral approach, then crystal approach is not burdensome. But if you cannot do lateral approach, then while handling issues that you can come up on the crystal approach, it might be tricky handling those issues. Due to time, whether I can do my presentation, but let me get started. In terms of short implant, actually, in all my surgeries, I always need a reference because I'm teaching at a university. So if I may share my reference, short implant when in sinus, is it safe? I also looked up literature, and as Dr. Kim said, conclusion-wise, survival rate, be it short or long implant, there's not much of a difference. So of course, when it comes to complication, short implants, they say, has less complication. And complication here, they mean biological complications. So marginal bone loss or peri-implantitis, compared to long implant, they have less, because long surgery and because of the more bone grafting, that's the result. So short implant, they say, is more favorable. Now this one, so meta-analysis systematic review by Dr. Kim, and this one is included in the system review. So they see RCT of comparing 6 to 11 millimeters. So they set the patient, placed at the multi-centers, and looked at the results. So 1 year follow-up is short, but it gives credible result. What it says is that they analyze by cost and the discomfort of patient and surgery time. And in terms of survival rate and complication, there's not much of a difference. But patient discomfort, there is a difference. And surgery time took longer and it was more expensive. Lateral approach, of course, is more expensive. So they said short might be better. And that was reflected in that Dr. Kim's systematic review paper. So short implant less than 8 millimeters being more stable, once you have that conclusion, then there will be generation where you don't really need to use long one anymore because there are scientific proofs. So now I also go with about 8 millimeters implant. And on another systematic review, short implant and long implant was again compared. And the reason I opted for this literature is that the implant survival, marginal bone loss, and complication and prosthesis failures, or statistically, there's no significant difference. But in systematic review meta-analysis literatures, if you see them, you always have this type of graphs like this. And if you look at that, there is a line, and on one side, favor short implant, the other side, they say favor standard implant. And if you look at this graph, you see the tendency. Now, all three, there's not significant difference, but they are more leaning towards standard implant, right? So standard implant actually overall shows favorable results, but statistically not significant difference. So statisticians would say there's no difference, but for clinicians like us, you see this tendency, and we also feel it in our clinics. So complication-wise, actually same as other literatures. There's less complication, biological complications for and prosthetic failures against similar results. And in terms of biological complication, short has a favorable result. So short implant, when it comes to biological complication, they have less. And biological complication is the biggest reason for peri-implantitis and for removing implant. So it seems short as a favorable result, more favorable result. But as Dr. Park, I think what he said is, is shorter implant possible? What do you think about short implant? He asked. And if you look at survival rate, first you have 8 millimeter implant was regarded as short, and compared to that longer than 8 millimeters. And it shows survival rate now is not much of a difference. If you see the graph, short is actually tendency-wise a bit better, but when it comes to standard versus 8 millimeter or less, so 7 or 6 millimeters, then standard actually becomes much better. So if you consider extra short, so you have short implant, survival rate is okay, standard, and then extremely short or extra short, that would be the survival rate based on this scientific evidence. So what is the load distribution is something we also need to think about. We mostly use as internal type. And load in the prosthesis, internal is disadvantageous. TS is disadvantages and SS. And the load is in the abutment and where it comes touch with the implant. Even there is a fixture, there is a load there. And when the load that is on the implant fixture, if it's vertical load, then it's overall distributed. But if it's oblique load, then it's focused on the apex side. So the side rather than the bottom of the apex. So you have to remember that. So in the sinus lifting, if you have less bone in apex, you don't have to worry about that because bone is sufficiently around implant, even if the apex is not filled, it's okay. Although it was mentioned briefly, without bone grafting on the sinus and implant acting as stenting and putting the Schneider membrane, of course, it was animal study, but histology shows that on the apex side, there is a kind of, under the Schneider membrane, there's a kind of a line. So I think that's also helpful results. So when there's a load rather than apex, it's the apex side that's impacted. So considering that, elevation like that would be okay, is what I think. But if you look at another finite element analysis, longer or standard implants produce lower stress. So standard is favorable than in terms of load distribution. So this type of literature is already available. So just opting for short implant is not easy given such an evidence. So this literature is really important because it shows histology, and it also has a lot of things we already discussed. So this is from Yonsei University, from Dr. Lee Jong-seok, and looked at the actual first human histology. So there was a donation, and we were able to see histology. So it's a really precious data. So it's from 2017, and if you look at it, BCP graft material was used, and one is general implant and another one is taper defects I or S company's implant. And as you can see on the left side, it was a bit higher. No, sorry, this is right side. It's a bit more higher, and this is a bit lower. And later on, after 6 years, to the apex, it becomes lower. Now, as you said, there's healing, and we can now look at the tissues. So we took the micro CT, and you can see inside of the sinus, and you see bones that have not been ossified. So BCP material, and I think bone is 4 to 6, and so beta BCP is a bit higher, but the graft material you see like as a dot around implant. Same here. So let's look at the histology. So bone elevated, and because of the particles, even if you're concerned, you see new bones have been formed. So you don't really have to worry about this. Of course, it took 6 years, but what in the residual bone, it can sustain that time. And if there's no loading failure, then bone that is there can last. And with time, it will be resorbed. So that's okay. And here, if it's a bit loose, then including elevation, including apex might be better. So there's a bit thin area, but no problem in function. So in terms of load distribution, it will touch the apex side. So I think it would be okay. So for me, short implants, I do believe you can use that. Short implant compared to long implants, I think it's okay. But too short ones, there's not much of a proof yet. So I said, 8mm implant, I would opt for that at least. And when you do crustal approach, as was mentioned, this side, if you can expand, and filling that with sufficient bone, I do believe is also important. Yes, thank you. Dr. Kim Kyoung-won, Dr. Kim Yeong-taek said a lot of good things, and I hope Dr. Park, it's been helpful to you. Now, I was thinking of going even for 6 or 6 millimeters, but maybe not anymore. So maybe do better sinus lifting. So anyways, I don't know whether I will really use 8.5 rather than 7 millimeters from now on. Well, I am persuaded quite a bit, but anyways, I will think more about this and try to give some change in my clinical setting also. And Dr. Kim Kyoung-won and what Dr. Kim Yeong-taek has said, most things I am in agreement. And short implants, in terms of survival rate, if there is a difference, then of course, in the future, I will also try to be more conservative. Yes, thank you very much for today's discussion. Now, today, we looked at, short implant or long implants. So I hope the discussion has been helpful to you all. And thank you, Dr. Park Jong-won, for that good case. So with that, I would like to conclude this session. Thank you very much. See you next time.
감사합니다. 수고하셨습니다.